you. More than a presentation, this is a quick, a private, quick introduction for this session. As you know, ventilator-assisted modes are more and more popular, let's say, in our unit. What does it mean, assisted ventilation? Assisted ventilation are the situations in which the patient and the ventilator share the work of breathing, more or less, and there is a continuous crosstalk. This crosstalk between the patient and the ventilator can be harmonious, let's say, but sometimes it is not so good, and the patient develop asynchrony. Patient-ventilator asynchrony can be defined, as a matter of fact, as a mismatch between the patient and ventilator inspiratory and expiratory time. This is the simplest definition I found in the literature. Why is it a problem so huge? Because with the current technology, the machine takes the signals very far from where they are generated. This was already showed yesterday. And in an ideal world, we should trigger the ventilator by using signals from the central nervous system or from the phrenic nerve. Conversely, if you are at the bottom of the cascade and you work with airways pressure and flow, it is not surprising that there can be problem. I don't have time to describe all the asynchronies, just let's define the two main kinds of asynchronies. We have phased asynchrony that can be divided in inspiratory trigger asynchrony. The worst effort is the that I showed in my previous presentation half an hour ago, or missed effort is the king of inspiratory trigger asynchrony. However, it is much more common, above all in pressure support, to have expiratory trigger asynchrony. Another kind of asynchrony can be defined as flow desynchrony. Very simply, we can define the flow desynchrony as a mismatch between the flow required by the patient and the flow generated by the machine. Which can be the risks associated with patient-ventilator asynchrony, and why, in my opinion, despite the evidence is not so high, we should look for resynchronization. Usually, traditionally, in the past, the time spent on mechanical ventilation was divided like this. A huge period of full support, then when the patient was considered ready for weaning, quite huge depending on the diagnosis, main for COPD, smaller for post-op patient, as an instance, weaning time. And when the mechanical ventilation discontinuation criteria were met, finally, after another small time, was the discontinuation. However, when you use, from the beginning of the story, assisted ventilation, sometimes the description of the time spent on mechanical ventilation can be more like this, with a short period of full support and a longer weaning time. Which are the factors complicating weaning? I don't want to stole the job to Laurent Brochard, but as you know, we have several factors that can complicate weaning. Among them, very important, very common, poor residual respiratory function, hyperinflation, impaired load capacity ratio, sleep deprivation, many comorbidities, and possibly, and this is what I will discuss in the next 4 minutes, patient-ventilator asynchrony. Can we consider patient-ventilator asynchrony as a factor complicating weaning? Well, there is some evidence that probably yes. The first paper, which is never cited, but is the first paper on this topic, was published by Shao and co-workers in Chest. What they did, they worked in a weaning unit, and they evaluated a small group of 19 patients who, with a high level of trigger asynchrony. More than 10% of the breaths were not correctly triggered, so they had a lot of wasted effort, etc. And they followed the clinical outcome of this patient. And what they observed is that only 3 of those patients with high patient-ventilator asynchrony were weaned. 9 of them failed to wean, and 7 not only failed to wean, but died. And so they conclude patients with trigger asynchrony took substantially longer to wean and overall had a very poor prognosis. For many, many years, this topic, after this study, has remained abandoned, I would say, till the paper already discussed this morning from Laurent Brochel's group showed two important things. One is that it is, although it is not the perfect technique, the perfect approach, you can, from the simple inspection of airflow and airways pressure tracing, you can detect a huge amount of asynchronies like inspiratory ineffective triggering of or expiratory ineffective triggering or double triggering, etc. But more interestingly, that all those patients that present an asynchrony index higher than 10%, that means that more than 10% of the breaths are asynchronous, they, if compared with those patients with lower than 10% asynchrony index, they show a dramatically increased duration of mechanical ventilation. Many of them require more than 7 days of mechanical ventilation, and many of those patients, 33%, 1 out of 3, requires tracheostomy. These data have been fully duplicated in the other part of the ocean by Marjolaine DeWitt from Scott Epstein group with above the same number of patients enrolled. And also in this study, it was quite impressive to observe that those patients with an asynchrony index higher than 10% had a longer duration of mechanical ventilation, a lower 28 days survival, a longer ICU length of stay, and a longer hospital length of stay. And here you can see maybe in a more simple way on the Kaplan-Meier plot, those patients with at least 10% of asynchronous breath had a much longer length of mechanical ventilation if compared with the patient with less than 10%. The same group made some, in another study, an important evaluation, an important observation. They observed that the asynchrony index is strongly related with the use of some sedatives, mainly non-opioids, so lorazepam and propofol, that have probably a direct effect on respiratory muscle strength, respiratory muscle contraction, a little bit less of morphine, and with the duration of continuous infusion of sedatives. And interestingly, there was a relationship between the RASS scale, the sedation scale, and the ineffective trigger index. For 1 unit of decrease in RASS, so for a heavier level of sedation, the incidence of ineffective triggering increased by 2.7%, suggesting that sedation is a part of the story. Another important risk associated with thank you, Marco, for this paper. Another important paper associated, another important aspect associated with the risks connected with patient ventilator asynchrony is the deprivation of sleep. In this nice study, patients were evaluated during sleep when receiving PAV and pressure support, and it was quite impressive to observe first that with PAV the patient reduced, halved, as a matter of fact, the rate of total asynchronies and had much less arousal, awakenings, and tended to have an increase in REM sleep, suggesting that when we work on the resynchronization in patients with high asynchrony index, probably we make our patient to sleep better, in a better way. And this can have major importance if you consider that, just as an example, sleep can interfere with the immunitary system reaction. This is my last slide. It is important to go on with new techniques that increase the level of resynchronization. In this study, it was just accepted in intensive care medicine. Roberta Costa and Cole compared with the same level of applied pressure, 2 periods of pressure support with PAV Plus that has been extensively discussed this morning by Laurent Brochel, so I will not waste time. And during the study, they were able to show that the time of synchrony that can be defined as the time in which the respiratory system of the patient, the respiratory muscles of the patient, and the ventilator push perfectly in phase, was significantly increased during PAP plus if compared with perfectly clinically settled pressure support ventilation. So my conclusion of this short introduction is that probably asynchrony is important. We don't have data till now showing that this is a major point in terms of survival of our patients, but by sure there are several risks associated with a high amount of asynchrony, and in the next future probably we will have to go on the research on new innovative modes able to allow resynchronization of our patients. Thank you.